Hey guys, got another pathology talk for you. Today's topic is going to be the inflammatory arthritises. As I've progressed through my different years in medical school, I've noticed some trends in the MBME and USMLE tests. The tests love to touch on problems that correlate to the basic sciences where they can integrate your physiology and pathology. Similarly, tests are also going to touch on processes that can have similar presentations and then focus on the key differences that allow you to differentiate these different pathologies. One common set of conditions that I've seen tested a lot on Step 1 and the shelf exams, which will also be useful for your clinical years, is the arthritides. A common chief complaint listed is joint pain or joint swelling, so your arthralgias or arthritis. When a question stem describes a patient's joint pain, the first thing to look at is the timing and acuteness of the symptoms. If there is an acutely swollen, red or erythematous, tender, warm joint with decreased range of motion, plus or minus a toxic patient, the list of things on your differential diagnosis is relatively short. I'm going to come back to this in a moment. On the other hand, if the onset is a little more indolent or insidious, you'll end up on this side of the algorithm, the chronic arthritises. Next, you need to ask if it is inflammatory or not. If it is not an inflammatory chronic arthritis, it's likely osteoarthritis or degenerative joint disease. On the other hand, if it is inflammatory, then you need to look at the number of joints involved. Typically, an inflammatory chronic arthritis involves multiple joints, either oligoarthritis or polyarticular arthritises. Yes, it can be an acute or sometimes initial presentation or flare of a chronic arthritis. For example, a rheumatoid arthritis or connective tissue disease like lupus can be a single joint, or one of the seronegative arthritides like psoriatic arthritis. But in these cases, the onset is more indolent compared to what we're going to talk about today. Also, there are typically systemic symptoms in the patients of the right demographics, a young to middle-aged female for the connective tissue diseases like lupus. I like this algorithm to keep the diseases straight in my mind, although there may be some overlap or gray areas along the way. What I want to discuss today in this video is the truly acute, inflammatory, monoarticular forms of arthritis. These truly acute arthritises, the patient will be okay one day, and then overnight there is a sudden rapid development of pain, swelling, warmth, redness, and loss of range of motion. No, it doesn't have to occur overnight, but that is a good way to think about it. All of a sudden they went from great to these severe symptoms. The patient may even be toxic. They can have the SIRS, Systemic Inflammatory Response Syndrome, symptoms, including possible fever, tachycardia, tachypnea, and an elevated white cell count. Now your differential diagnosis is very short. You need to be thinking about septic arthritis, the crystal diseases like gout or pseudo gout, or a reactive arthritis, previously known as Reiter's syndrome. We're going to go through the relevant pathophysiology of all these conditions, arthrocentesis findings, and briefly touch on treatment possibilities that can help tie everything together. I won't be going into Reiter's syndrome today, which is also known as reactive arthritis. This is a reactive arthritis associated with GI and GU infections. So this can either be Yersinia, your GI conditions, or chlamydial, being a GU STD. It's a triad of conjunctivitis, urethritis, and arthritis. Remember this by the mnemonic: you can't see from conjunctivitis, you can't pee from urethritis, and you can't bend a knee due to that inflammatory arthritis. So going back to those acute arthritises, the next step is always to perform an arthrocentesis or tap the joint. This might not always be true in every clinical setting, but it is the right test answer. For example, a patient that has multiple flares of gout comes in with a gouty-like presentation. You don't always have to tap it, but on a test, they are going to want you to perform an arthrocentesis as the next best step. Joint fluid aspirate should be sent for a cell count with cell differential, gram stain and culture, glucose levels, and analyze for crystals. With the results of the joint aspiration and a clinical correlation, you can normally make the diagnosis. So let's start with septic arthritis. This is the big bad feared form of acute arthritis. This is because the organisms involved in acute arthritis are typically very virulent and can quickly destroy a joint. The cartilage is destroyed, resulting in early onset degenerative joint disease with bone-on-bone grinding, pain, and stiffness. Organisms of any kind can affect the joint, and mostly occurs through hematogenous spread and seeding of the joint, or it can be direct inoculation from trauma or surgery, or a contiguous spread from a cellulitis or osteomyelitis. So suppurative arthritis, meaning purulent or pus-filled arthritis, is due to bacterial infections of the joint. Like I said, any type of organism can affect it, for example, a virus or a fungus, but it's mostly bacteria that you think about, especially with suppurative arthritis. The most common cause of suppurative arthritis is hematogenous spread from a distant site. The most common cause is Staph aureus in both kids and adults, but you want to consider Neisseria gonorrhea in sexually active adolescents. I'm sure that you have heard of the association between salmonella and sickle cell. While it is true sickle cell patients are more prone to salmonella, osteomyelitis, and arthritis, the most common cause of these is still staph. So there's two ways this can be worded. They can give you a patient with salmonella, osteomyelitis, and arthritis and say, what underlying condition does the patient likely have? In that case, the answer is sickle cell. But on the other hand, if they give you a sickle cell patient with osteomyelitis or septic arthritis and they say, what is the most common bug? They're going to have salmonella on there, but it is not the right answer. In that case, it is staph because it is the most common cause no matter what. Risk factors for suppurative arthritis include immunocompromised states, any chronic arthritis which predisposes the joint to this infection, and IV drug users with hematogenous dissemination. A key to differentiating the causes of the bacteria is the number of joints involved. In non-gonococcal cases, meaning non-Neisseria gonorrhea, there is typically a single joint involved, and that monoarticular arthritis occurs most commonly in the knee, more than the hip than the shoulder, knee being most common caused by staph. On the other hand, gonococcal arthritis from Neisseria is typically an asymmetric migratory oligoarticular arthritis, meaning a few joints involved within the long bone joints, most commonly the knees, the elbows, the wrists, and ankles. Disseminated gonococcal infections are not always associated with genitourinary symptoms and may be asymptomatic in the genitourinary system. Look for oligoarthritis associated with tenosynovitis of the wrists and hands, for example, Descartes veins, and a dermatitis, which is typically maculopapular or pustular, meaning small pustules with associated erythema around it. A helpful mnemonic to remember gonococcal arthritis is STD. It is a sexually transmitted arthritis with tenosynovitis and dermatitis syndrome. The key here is the pathogen. When staph or gonorrhea reach the joint, the synovium causes a huge inflammatory response by releasing inflammatory mediators, recruiting neutrophils into the joints. These activated PMNs are going to come into the joint and release different proteolytic enzymes in an attempt to fight the invading organism. The problem with this is they secondarily will damage the articular cartilage with these reactive oxygen species, proteolytic enzymes, and different things that are trying to destroy bacteria, but accidentally destroy the articular cartilage. Once destroyed, your articular cartilage cannot regenerate and the joint is destroyed. This can occur as fast as 8 hours. So an acute septic joint is a big deal. Workup and treatment must be very speedy to save the joint. Here the treatment is surgical. You take the patient back to the OR, get your cultures of the joint fluid, wash out the joint with normal saline, and then start IV antibiotics only after cultures have been taken, because remember, giving antibiotics before cultures are taken can mess up the culture results. The other major class of the acute arthritis that I want to talk about is crystalline arthritis. Whether it's gout or pseudo-gout being CPPD disease, calcium pyrophosphate deposition disease, there are endogenous crystals of some kind deposited into a joint. It is these crystals that are phagocytized by neutrophils, resulting in the activation and a cytokine-mediated cascade causing inflammation and cartilage destruction. So let's start with gout. Gout is a disease of acute flares of inflammatory arthritis due to monosodium urate crystals in and around joints. This can be a primary process where the arthritis predominates, or it can be a secondary cause of secondary gout. For example, due to another pathology like increased cell turnover in leukemias and lymphomas. Central to gout is hyperuricemia. Once gout levels are greater than 6.8 milligrams per deciliter, you can develop gout. They are required but not sufficient to cause gout. As mentioned, this is a great topic for USMLE Part 1 because it integrates the biochemistry you learned first year from purine catabolism. We're going to start there. You should recall there are two main pathways for purine nucleotide production. There's the de novo pathway, where nucleotides are synthesized from non-purine substrates, and there's the salvage pathway, where purines are created from purine metabolites from dietary intake and catabolism of cells. The salvage pathway is a recycling pathway. The two major purine nucleotides are AMP, adenosine monophosphate, and GMP, guanosine monophosphate. Both AMP and GMP are cleaved by the nucleotidases to adenosine and guanosine respectively. Adenosine is then broken down by adenosine deaminase to inosine, and inosine and xanthine from XMP, and guanosine are then acted on by purine nucleoside pyrophosphate phosphorylases, PNP, purine nucleoside phosphorylases. Inosine will be converted to hypoxanthine, and guanosine is going to be converted to guanine by PNP and then converted onto xanthine. Guanine is acted on by guanine deaminase to make that xanthine, and from xanthine oxidase is going to convert xanthine onto uric acid. Uric acid is the end product of this purine breakdown pathway. Uric acid is then filtered by the kidneys. Majority is going to be absorbed in the proximal tubules. Remember how it increases medullary tonicity, and a very small amount is resecreted into the distal nephrons and lost in the urine. Also note that the enzyme here, hypoxanthine guanine phosphoribosyl transferase, HGPRT, is going to recycle hypoxanthine and guanine to IMP and GMP respectively. This enzyme is going to be important soon. So how does one develop hyperuricemia? This can either be due to urate overproduction or decreased urate excretion. It can also be due to some combination of the two. Vast majority of primary gout is due to underexcretion of uric acid. These underexcretors are due to some decreased renal secretion of uric acid. Only a small percentage of gout is due to overproducers of uric acid. Of those with increased production, only a minority of those patients have an identifiable gene defect like a reduction in HGPRT. HGPRT is needed for the purine salvage pathway, and when a patient has decreased function of HGPRT, purines are not salvaged and therefore shunted down the catabolic pathway, resulting in increased uric acid production. You should remember from your genetics class that there can be a complete absence of HGPRT. This condition is known as Lesch-Nyhan syndrome, inherited in an X-linked recessive pattern. Technically, Lesch-Nyhan is classified as a secondary gout because the neurological symptoms are so predominant and overwhelming compared to the gouty arthritis. Very high levels of uric acid lead to severe mental retardation by being deposited in the CNS, along with movement disorders and self-mutilating behavior, including biting of the fingers and lips. Other secondary causes of gout can be seen with increased cell turnover or cell lysis, for example, tumor lysis syndrome, when chemotherapy is initiated for leukemias, or a decreased excretion in patients with an underlying primary chronic kidney disease. How does uric acid lead to inflammation? When monosodium urate precipitates into crystals in the joints, there is an inflammatory response and endogenous cytokine production, leading to white cell recruitment and activation. When your macrophages within the joint phagocytize the MSU crystals, the internal inflammasome is activated. This is an organelle that leads to a signaling cascade, starting with caspase 1, ultimately leading to increased levels of IL-1. IL-1 is one of the acute phase reactants that recruits neutrophils to the joint and is also a pro-inflammatory mediator. The infiltrating activated PMNs will then release further cytokines, free radicals, and proteases, which lead to inflammation and cartilage damage. Notice the correspondence to how your own cells lead to articular damage in a bacterial suppurative arthritis. Also, MSU crystals can directly trigger complement, leading to further activation of complement, neutrophil chemotaxis, and release of your inflammatory mediators. This sums up to tissue injury and inflammation. Many different factors can lead to the precipitation of crystals. As I mentioned, monosodium urate is deposited in the synovium and surrounding tissues of the joints, but then they need to precipitate to cause this inflammatory attack. Both the solute of the urate and temperature affects the solubility. Synovial fluid is a worse solvent for monosodium urate, thus crystals will tend to precipitate in joints more than plasma. Similarly, cooler temps are going to shift you to more precipitation of crystals. This makes sense. What joint is most commonly involved is the first MTP joint of the great toe. This peripheral joint is very cool and encourages the crystals to form. For the sake of completeness, remember that the second most common joint involved is the knee. So what other risk factors lead to gouty arthritis? Age, genetic predispositions, heavy alcohol consumption, a very high purine diet like red meats and seafoods, obesity, lead toxicity, and certain drugs like the thiazides causing hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Gout has 4 stages. The first stage is asymptomatic hyperuricemia. This is exactly how it sounds. There are no symptoms, and they have those uric acid levels over 6.8. Second phase is the acute arthritis with the acutely inflamed joint. Majority of patients will have the first attack be monoarticular, and about 50% will occur in that first MTP joint. 90% of patients will have additional joints involved, including the instep of the foot, ankle and heels, knees, wrists, fingers, and elbows. The acute flare is normally self-limited, lasting hours to weeks before complete resolution. Next is the third stage, which is the asymptomatic intercritical period. After the acute phase resolves, there's a period of time where there are no symptoms. Majority will have a second acute flare within months to years. And finally is the fourth stage, known as chronic tophaceous gout. Chronic tophaceous gout occurs about 12 years after the first attack on average. Chronic tophaceous arthritis is due to the formation of tophi. Histologically, these tophi are large amounts of MSU crystals covering the articular surface. Tophis are masses of uric acid crystals and then a reactive tissue formation around them. The synovium undergoes hyperplasia, becoming thick and fibrotic, forming a pannus around it due to the chronic inflammation from the tophi. It is this pannus, similar to a pannus of rheumatoid arthritis, that destroys the underlying cartilage and even bone reabsorptions and erosions around the joint. Your radiographs are going to show periarticular bone loss or erosions known as rat bite lesions due to this bony reabsorption and joint space loss. Tophaceous gout will lead to joint destruction and eventually crippling pain and loss of function. Tophi can also form outside of joints, commonly on the helix of the ear. Additionally, you can find tophi on ligaments, tendons, and bursa. These tophi histologically will show large aggregates of crystals surrounded by white cells in a giant cell reaction, like a foreign body reaction. In the tophaceous stage, patients are going to develop renal impairment with chronic gouty nephropathy occurring due to the formation of stones, uric acid stones, and tubular obstruction. Uric acid crystals in the urine are radiolucent, meaning they can't be seen on x-rays. They are rhomboid shaped and will precipitate out in acidic urine. I'll come back to joint fluid analysis later, but one key to remember with gout is that you must know cold is the appearance of the crystals. Urate crystals are described as long, slender, and needle-shaped, found in the synovial fluid and occasionally within the cytoplasm of neutrophils. Uric acid crystals are negatively birefringent. This means that they are under polarized light, they will be yellow to parallel light and blue to perpendicular light. How I remember this is gout is negative, or gouty MSU crystals are negatively birefringent, whereas the other CPPD disease is positively birefringent. Gout is negative birefringence. This is extremely common to see on an exam or test, and use this mnemonic. It is yellow under parallel light. The L's are parallel, yellow being parallel for gout. Finally, I'll quickly talk about treatment. If someone comes in with an acute flare of gout, do not give them the anti-gout drugs like allopurinol. That will be low-hanging fruit on a test, and it is the wrong answer. In the acute phase or acute flare, patients need some type of anti-inflammatory like NSAIDs to cut down the inflammation. Give ketorolac or ibuprofen. If they can't take NSAIDs, for example with kidney impairment, then colchicine is a second-line alternative. The worst choice is corticosteroids for the acute phase, and you use these if the other two are contraindicated. On the other hand, there are anti-gout drugs for those that are in the intercritical phase and not the acute flare. There are two main classes of anti-gout drugs. One class is going to decrease the formation of uric acid. The second class is going to increase renal clearance of uric acid. If you remember, the majority of patients are under excretors, but you will still start with the class of drugs that decreases the production of uric acid. These are your xanthine oxidase inhibitors. These two drugs are allopurinol and febuxostat. Xanthine oxidase inhibitors are going to block the conversion of hypoxanthine to xanthine and xanthine onto uric acid, so decreasing the production of uric acid. Second class of drugs is probenecid and sulfapyrazone, which are your uricose uric drugs. They increase the uric acid in the urine. These increase renal clearance of uric acid by inhibiting the reuptake of uric acid from the renal tubules, thus it is lost in the urine. You do not want to use xanthine oxidase inhibitors or uricose uric drugs in the acute phase. They can acutely increase the levels of uric acid during acute flares and cause a worsening of symptoms. Just treat the symptoms in the acute phase with anti-inflammatories and then later start on preventative medicines. So once you understand gout and have it down cold, the last pathology you need to understand is fairly easy. It is pseudo-gout. Pseudo-gout, or CPPD disease, calcium pyrophosphate deposition disease, is similar in the process of crystals precipitating out in the synovial fluid and causing an inflammatory response. This is all the same as gout. The difference is the composition of crystals, risk factors and associations, and clinical findings. CPPD disease is also known as chondrocalcinosis. Break down the name. It's calcification of cartilage. Chondro is cartilage, calcinosis being calcification. I'll show an example of what this looks like on an x-ray later. Typically, a CPPD patient is over 50 years old, majority being over 85. CPPD disease is completely idiopathic, but there are also hereditary and secondary forms. CPPD disease can be inherited as an autosomal dominant form, and this has an earlier onset in a more severe osteoarthritis as a result of joint destruction. The mutation detected here is a pyrophosphate transport channel. In contrast, the secondary forms of pseudogout are due to another underlying process. This can occur due to prior trauma or joint damage, for example, motor vehicle collisions, hyperparathyroidism, and the resultant hypercalcemia, hemochromatosis, hypothyroidism, and diabetes. The association of pseudogout, CPPD disease, and hemochromatosis is very commonly tested on USMLE Step I. Remember that. So in patients with pseudogout, the crystals first form in the articular cartilage, menisci, and intervertebral discs. Once large enough, the deposits actually rupture into the joint, and this causes the inflammatory reaction. Patients typically do not have symptoms, and when there are symptoms, it can present with acute pain and swelling, and it can look like gout, and hence the name pseudogout. Unlike gout, though, there can be no acute phase ever and simply causes subacute or chronic arthritis, presenting like a chronic arthritis, for example, osteoarthritis and rheumatoid arthritis. Symptoms, if present, can last for a few days, like gout, and out to weeks and months, and affect a single or multiple joints. In other words, CPD disease can present like many different forms of arthritis, and it must be high on your high suspicion to make the correct diagnosis, as it can masquerade to look like many different forms of joint conditions. The knee is the most commonly affected joint in CPPD disease. Look for a knee with chondrocalcinosis. In asymptomatic patients, this is found on an X-ray taken for some other reason. This is what an X-ray will look like in CPPD disease. So an X-ray will normally show your calcifications of the bone, but look in the joint space and you'll see actually calcifications of the cartilage in the joint. Where there's normally joint space in cartilage, which is radiolucent and not seen on an X-ray, here it'll be calcified in bright white, as I've demonstrated here. For example, the X-ray of a normal knee will show an area of radiolucency between the femur and tibia. This is cartilage and menisci, and when there's no calcification, it is not seen. On the other hand, though, when there is calcification, it will now be radiodense, and you'll see the bright white crescents here with the cartilage, as opposed to the healthy native knee. The next most affected joints are the wrists, elbows, and shoulders. An important thing to remember is that about half of patients will have significant joint damage. CPPD disease can lead to loss of the joint and ultimately osteoarthritis and degenerative joint disease. Again, I will talk about the most important histology. Grossly, CPPD disease crystals are large, chalky, and white deposits that are friable. Under microscopy, the crystals will appear rhomboid in shape as opposed to the needles of gout and are weakly positively birefringent. Now that they will be yellow under perpendicular light and blue under parallel light. Inflammatory cells will also be seen infiltrating the joint and are typically less severe than gout. So CPPD crystals are positively birefringent. They will be yellow under perpendicular and blue under parallel, as opposed to gout, which are negatively birefringent, yellow under parallel, blue under perpendicular. Unlike gout, treatment is simply supportive. The crystals cannot be stopped, and while you can treat an underlying or primary disease process like primary hyperparathyroidism, the treatment is largely supportive. Give the patients NSAIDs over colchicine for the acute phase and steroids as your last line resort. Finally, let's finish with joint fluid analysis. The joint fluid analysis, or aspirate that I talked about earlier, should be sent for cell count with differential, gram stain culture, glucose levels, and crystal analysis. With the result of a joint aspiration in the clinical correlations, you can normally make the diagnosis. So a normal joint fluid will be low in volume and be clear or slightly yellow straw colored. It will be fully transparent and thick with a high viscosity. There will be less than 200 white blood cells and less than 50 total or 25% PMNs. Obviously, there should be no crystals, negative gram stain, and culture. In a non-inflammatory joint, for example, a patient with osteoarthritis, the joint fluid is a light straw color to yellow, but again transparent with a high viscosity. It's thick. There is elevated white cells, but still less than 2,000 in total, and this is due to irritation of the joint from loss of the cartilage or trauma. The key here is cell count is very low and less than 25% PMNs. There's very few acute inflammatory cells, and there's more chronic macrophages and lymphocytes in the joint. Again, negative for crystals, gram stain, and culture. Then you get to the last two categories, and these can be very tricky to tell apart and require clinical correlations. In an inflammatory arthritis, the color of the joint fluid is still yellow, but there can be some cloudiness due to exudative processes and high protein and cell burden. There is a medium viscosity due to this exudative process and more total fluid. Overall, the joint can be swollen. The key here is white blood cells are over 2,000. They will be over 2,000 in either an inflammatory or an infectious septic arthritis. In contrast, a normal or non-inflammatory joint will have less than 2,000 cells. The inflammatory arthritis, being a more acute process, will have 2,000 up to 100,000 white cells, but it can even have as many as 75 to 100,000, typically the 2,000 to 100,000 range. Crystals can be seen either as the needle-shaped negatively birefringent monosodium urate crystals or rhomboid positively birefringent CPPD crystals. Always remember this though, crystals being present does not rule out a septic arthritis. A damaged joint from crystal disease may very well have an infection, but if it's purely crystal disease, then there will be a negative gram stain culture. Also, inflammatory arthritis, like a rheumatoid arthritis, may have a lower cell count, but it have negative crystals. You'll still be over 2,000. Finally, in septic arthritis, the color of the synovial fluid will be yellowish green and cloudy. It can be even grossly purulent, so meaning opaque and pussy. Viscosity is actually pretty low due to the exudative fluid diluting it out. Again, white cells will be high, over 2,000 indicating an acute inflammation, but typically in a true septic arthritis, white cells will be very, very high, normally over 80,000. Certain bugs like Neisseria gonorrhea or Lyme's arthritis may have lower than 80,000, but will still be an inflammatory level. Neutrophils will be very high, typically greater than 75%, maybe even into the 90%, so a very high PMN load. Gram stain will be positive, and culture should be positive, although it may be falsely negative. So when you go to look at numbers on an exam, use 2,000 as your number of white cells as a good place to start. That will differentiate your non-inflammatory or a normal joint from an inflammatory and septic arthritis. Also use your clinical correlation, how toxic the patient is, and percent of PMNs to help you make this judgment call. So hopefully this has been a solid overview of the arthritides for you. This is definitely going to come up both in emergency and inpatient medicine, also in ambulatory medicine. Good luck studying and thanks for your attention. Let me know if you have any questions, post them below and I'll get back to you as soon as possible.